Today we're going to talk about pharmacokinetics. So you'll remember that pharmacokinetics involves absorption, distribution, metabolism, and excretion. So you'll remember that absorption is the way that the medication gets absorbed. So medication is taken orally, goes into the stomach, and starting absorption occurs in the stomach or the duodenum, the small intestine. That then the medication gets absorbed into the blood, and the blood will then distribute the medication to the site of action. And metabolism occurs next, and several things happen with the metabolism. We can either metabolize or change that drug to a different form so that it's active, or the liver then can break down the medication, rendering it inactive. It just depends on what's the specific focus of metabolism. And then finally, the medication is excreted. So when we think about these four different components of pharmacokinetics, absorption, distribution, metabolism, and excretion, so think about what happens if you absorb a medication through the skin. So certainly it bypasses the GI tract, but it bypasses the GI tract into the bloodstream itself. So there are some administration approaches where medications can get into the bloodstream quicker than through the stomach. If you put tablets or liquids under the tongue, we have a sublingual approach that the medications can be absorbed directly into the blood, which is a much quicker absorption. So then again, by distribution, the blood is carrying medications to the site of action, either depending upon whatever that site of action is, depending upon the mechanism of action for those medications. But also the blood can carry medications to other sites. It can carry medications to the kidney or liver, depending upon what the approach is. And then obviously these are places where metabolism take place then, like the liver then can break down the drug, and then placement is the drug metabolites are then placed into the bile and it is excreted in some fashion, or medications can be metabolized or even metabolized in the kidneys, but also additionally excreted. So think about where the major site of drug metabolism occurs, and that's in the liver. So having good liver function in order to have drug metabolism is essential. You certainly want to have good kidney function for appropriate secretion. So drugs must cross membranes to move from the site of administration into the blood. So they have to move from the administration site, being GI, sublingual, skin, to the blood. But once it's in the blood, the medication's in the blood, they have to cross certain membranes that have to cross through the vascular system into the site of action. But they have to then cross these membranes and undergo metabolism, and finally excretion is needed. So if you think about this process, you have drugs that are moving from the system, from the vascular system into the cells, across membranes, and then back out, across the membrane into the blood again. So really absorption is the time and is the process that the drug enters the body until it gets into the bloodstream. So it's also a time when the drug becomes bioavailable. So just because you swallow a pill initially at 5:30 in the evening, when will this medication become biologically available? How long will it take the medication to be absorbed? Generally within the first hour. But if you give a medication through the IV, approach, you don't have to worry about absorption because we put the medication directly into the bloodstream. So that's why it's important that if you're giving medications through the IV system, that or through the IVs into the blood, there's no turning back. We have to be sure about what we're giving. So the term bioavailability then is the degree of which the drug becomes absorbed and transported to its targeted site. So really, things that are influenced by bioavailability really are things that are tablets that can potentially be dissolved pretty quickly, and it could be absorbed pretty quickly as well after the medication is broken down. But what if that medication is coated with a special substance that prevents the stomach acid from breaking it down? So enteric coated aspirin is a good example. That aspirin is very caustic to the stomach and can cause a fair amount of energy in the stomach. So if this enteric coating is on top of the aspirin, it will not be quickly absorbed and prevent any kind of gastric irritation. We do know that aspirin can be pretty caustic in causing a lot of ulcerations or gastritis that can cause some significant inflammation in the stomach as well. Also, there are some medications called sustained release formulations. They are not the same as enteric coated, but nevertheless is really important to understand because sustained released medications are they allow only a certain amount of medications to be metabolized at certain times during the stomach. So there may be a capsule that has multiple beads in it with different coatings on top of the medication that break down at variable rates so that these medications can be absorbed over a 24-hour period. So a special component of these medications are that these medications are never crushed, or that the sustained release capsules are never opened up and given to a patient through applesauce, because those medications may be absorbed much more readily or differently than the manufacturer's setup, so that once you break them up and give them to a patient via applesauce, then they get the full dose of, let's say, a 24-hour drug that you're trying to administer to the patient. So they have to be able to swallow capsules if they are a sustained release approach. Also, you have to remember that drugs are absorbed only across a fatty or lipid membrane. Now, you need to understand that there are some medications that can move through channels or pores. Medications like potassium or magnesium or sodium, some type of electrolyte approach. Medications that could be directly through channels. And then there are some medications that are crossing over to the bloodstream if they have a carrier approach. So something can grab onto the medication and then carry it across the membrane into the cells. But most drugs really penetrate the outer membrane. So the membrane has to be a lipid membrane in order for the medication to be absorbed through that membrane. So most drugs are absorbed across a fatty layer. And this is an example of the structure of the stomach that is important to focus on. So most drugs are absorbed in through the small intestine. So medications are taken orally. They begin their breakdown process in the stomach unless they have some enteric-coated medication and enteric-coated covering on them, and then go into the duodenum and then follow along with this small intestine. So this is a small snippet here of what the small intestine looks like on the inside. And then there's these villi, villus structures that you can see here are single celled type structures that allow a readily absorptive process to take place. So medications then go across these structures and are absorbed into the bloodstream. And this is a even more closely observant picture of the medication, of the villi and some of the structures inside there. So the drugs, again, that move across the membrane are important that they have to be lipid soluble, non-ionized, and we'll get into that a little later, meaning that they don't carry any electrical charge, but we'll get into that a little later as well, in order to absorb across the villus into the bloodstream. So this is another schematic that is showing different areas through from medication and transported molecules, through the carrier proteins that go to the inside of the section, through the lipid layer. So it's important that we understand how these medications then can be absorbed and transported across the membranes into the cell or the vessel or whatever the destination is from there. Drugs that do not go across the membrane are medications that do not have they have an uneven distribution of electrical charges. So these are ionized medications. So when you think about some of these medications is important. An example would be kanamycin is a medication that is an anti-infective, a medication that is given either IV or IM because it carries an uneven distribution of electrical charges. We can't administer it by mouth because it can't be absorbed, because it's not going to cross the membrane into the bloodstream. So the only way that we can give kanamycin in order for it to be effective is to either give it IV, intravenously, directly into the bloodstream, or intramuscularly into the muscle itself. So if you give it to the muscle, it doesn't have to cross the membrane. It can be directly absorbed into the vascular system from that perspective. Here's another example that I've provided here for you. The quaternary ammonium compounds, which are tuberculin, which are medications that can't be absorbed PO, and this is it's a paralytic agent. So trying to give some medications through the enteral approach is not necessarily, it's not going to be effective at all. So obviously giving it IV is going to be the most important approach. So an interesting little history fact is that some people who were hunter-gatherers and they were using arrows to kill their animals would put some type of quaternary ammonium compounds on the tip of their arrow. So when they shot the animal would die. But when the animals were cooked and eaten, the compounds would not pass through the GI tract to impact the person consuming the meat. So that, I think, is just kind of an interesting little tidbit about those quaternary compounds. So we have to think about, there are also medications that are weak acids or weak bases that are dependent upon ionization, or from the acidic or basic perspective. It really kind of depends on what kind of drugs there are, whether they're going to be administered to the patients. So weak acids and weak bases will switch between their ionized and deionized states depending upon the solutions that they're in. So that's really an important point to understand. So, and to begin to think about. So, if a drug is a weak acid, can become a weak base depending upon its environment that it's in. And a weak acid may be opposite, and weak base may be opposite as well. So remember what pH is. So it's a measurement of the concentration of free protons in a solution. So remember that a low pH means that you have a high concentration of protons. So a low pH equals a high or very acidic compound. So remember that the low pH is very acidic, and that a very high pH means a very basic solution. So when we think about weak acids and weak bases are converted or changed into their charged particles, that's when they become ionized. That's when they start carrying a charge. When they're ionized, they cannot be absorbed. Okay, so the pH of the environment really determines if either an acid or base becomes ionized. And remember, ionization is important for absorption. If they're ionized, they are not absorbed. Acids tend to ionize or release or give up their proton in a basic, or we also refer to that as an alkaline media. So if you take an acidic medication, it's going to be ionized in a basic environment. So there won't be much absorption because of that taking place. So bases then tend to be ionized in an acidic environment or media. So an example would be aspirin molecules. So we know that these aspirin molecules are non-ionized in the stomach. So we know that the stomach has lots of acid. So if you just take a regular acid tablet, where's most of the absorption going to take place? It's going to take place in the stomach. And it could cause, again, as we said previously, some irritation to the stomach, gastritis, irritation, because aspirin is being broken down in the stomach because it is an acidic environment. It's acetylsalicylic acid, salicylate, or acetylsalicylic acid as aspirin. That again, if it's in the stomach, it's going to be broken down in the acidic environment. There's going to be lots of absorption and potentially some significant damage. And on the other hand, again, bases tend to ionize or accept the proton in an acidic environment. Okay. So again, here is an example that acids are best absorbed or unchanged or deionized in an acidic environment. Okay, and bases are best absorbed or unchanged, deionized in a basic environment again. So this is an important concept for you to remember. So when we go down from the stomach, we have this acidic environment, but when we get into the duodenum, this area here past the pylorus of the stomach into the duodenum, we know that it's a basic environment. So that's important to think about in terms of where medications are then going to be absorbed. And this is important because the blood is generally an alkalytic environment. From your pH of your blood should be 7.35 to 7.45. So once the medication absorbs from the stomach into the vascular system, aspirin then becomes ionized so that it's not going to be absorbed back into the stomach, but it will stay
the vascular system to be delivered to the site of action.
When, again, we are ionizing something, we are giving up the proton, and it now becomes a negatively charged ion. So, again, ion trapping is an important concept because acidic drugs will accumulate on the alkaline side and basic drugs will accumulate on the acidic side. And then this potentially could lead to increased amount of medications in those areas. So those substances may become toxic because they are building up in those areas. So who cares? So, well, you do, really. So sometimes we as clinicians, if we can change the environment and remove the toxic substances from the blood by ion trapping, then we can potentially eliminate those medications where they can be excreted. So think about that. If you were to ingest or overdose a drug, you'd want to get it out of the body as soon as possible. So in order to do that, we would think about this idea or this way of treatment of ion trapping. And remember, ionization is a process whereby an atom or a molecule acquires the negative or positive charge. So acids are proton donors. They tend to ionize in bases. Well, the opposite's true for bases. Bases are proton acceptors, and they tend to ionize in acids. So remember, when acids give up a proton in basic media, it becomes a negative charge. When a base accepts a proton in an acidic media, it becomes positively charged. And once that takes place, the drug does not then pass back through the membrane. So I want you to think for a moment about angel dust, or PCP. So phencyclidine. It's a very basic alkaline substance. So what I really want you to see here is that there's a picture here of the nephron. So it's got really everything to do with how we're going to remove these toxic substances. So we know that blood will bring the toxic substances, or any substances really, to the glomerulus. So some of those products will then move across the glomeruli into the tubules then at that point. So then if we gave this patient who had overdosed on phencyclidine or PCP, if we give them the drug ammonium chloride, the ammonium chloride itself will make the urine into a very acidic environment. So when you think about what's happening in this tubule, when urine is excreted, and when we make the urine very acidic, that very alkalytic then substance wants to cross over into the tubule. So when it does, it crosses over into the tubule so that when the PCP is taken for the patient, or for the individual, it will cause, when we add in the alkaline substance, or when we add in the acidic substance, then it will pull the angel dust into the tubules, so it will not have its toxic effect into the individual at that point. So the ammonium chloride makes the urine acidified, drawing the basic substance from the blood that's caused by the phencyclidine into the tubule so that it'll be drawn away. So that you see by making the urine more acidic, we're able to pull away the harmful effects of the acid dust. So what are some of the things that affect drug absorption? So really, the idea that we just talked about was pH partitioning. So that's where a drug really is going to accumulate on the side of the membrane where the pH most favors its ionization. So remember, when it's ionized, it cannot be absorbed or moved back across the membrane. Okay, so really, how you think about some of the drug components that potentially could affect their drug absorption. So, for example, if you take some of those powdered headache pills, so if you take some of those headache powders, really is what they are, they'll be absorbed much more quickly because they have no outer coating. But if you use the enteric coating, take enteric coating or capsules, they're going to have a decreased degree of absorption. So surface area is really important. So the longer the surface area, the faster the absorption. However, if you think about, the other factor, if you have a shorter surface, then it's going to be absorbed much less quickly. But most enteral or PO or by-mouth medications are really absorbed throughout the small intestine rather than in the stomach itself. So some of the other things that can impact absorption are really blood flow. So if you have great blood flow passing by the stomach and the small intestine, then drugs are going to be absorbed much more rapidly. So if you have poorer or less blood flow to those areas, you're not going to have great absorption. So blood containing a newly absorbed drug will be placed rapidly by drug-free blood, which makes sense, right? So as the blood flow is coming by that area, there's a gradient where you have a new drug that's being absorbed, and then an empty blood, really, if you will, where the drugs are not present there. So the drugs are going to rapidly be absorbed into the bloodstream. So the greater the concentration gradient, the more rapidly the absorption will be. So this is really the concept of diffusion. So where areas where products move from the area of high concentration to the low concentration. So lipid solubility. So what do we really know? So in order for drugs to be absorbed, there has to be a lipid soluble membrane. So why do you really think lipid solubility made the list? Why do you think that would affect the solubility and the absorption of the drug? So really, we've already kind of talked about this. So in order for the drug to cross the membrane, it's got to be lipid soluble. So we also have to think about some routes of administration for our patients. So anything that goes into the mouth, into the GI tract, through the esophagus, through the stomach, through the duodenum, into the small intestine, we're talking about enteral, E-N-T-E-R-A-L. So within the gastrointestinal tract. So enteral. And on the flip side, anything parenteral that's given directly into the blood. It is via an IV or IM approach. I know IM is not really it is not IV. However, it's absorbed directly from the muscle into the intravenous, into the vascular system. So when you think about intravenous, whatever we're giving is going to be a rapid onset. We really don't have to think a whole lot about absorption for that medication because it's going to be distributed very rapidly. So when we're talking about intravenous administration, it's gonna be we're going to be very particular, very precise about the medication. So we're going to be focused on the very precise amount of medication that we're going to give to the patient. So if we give something to the patient IV, we potentially could administer large volumes because we're putting the medication directly into the vein. But we also really have to think about some of those medications that may be irritants. Some of those drugs may be irritating to the vessels themselves. And sometimes IV drugs can be very dangerous, but once we give them, they are irreversible. Sometimes they can be costly, and sometimes it can be inconvenient for the patient as well. So potentially whenever you give IV medications, we could give too much fluid. It could cause some fluid overload for the patients. And that could be dangerous for the cardiovascular system. So potentially if the heart has way too much volume, or the intravascular system, if the vascular system has too much volume, then we really have to be focused on being careful not to administer too much IV medications, especially for those patients who are already in heart failure. And this is a description here of the normal foot, some pinion edema, and you can see the different stages of medications, or different stages of edema there. Also, we potentially could cause some pulmonary edema for the patient. If there's too much too much volume in the vascular system, we could be overloading into the lungs as well, cause pulmonary edema. So if we're giving IV drug administrations, we need to give them slowly. Some, typically 2 to 5 minutes, sometimes it may be even shorter periods of time. But remember, we're giving a high concentration of the drug into a very short amount of time, and there's going to be a very large gradient because we're administering medication into a site that is drug-free. So when we're giving large amounts of fluid, then we're giving boluses of fluid. So it permits us to give a very large amount to really get appropriately desired concentration of the medication in the bloodstream itself. And there's really, if we're giving a continuous infusion, then once we reach steady state, then we could maintain the drug at various different levels. And certainly, some of those medications include heparin or insulin or other IV antihypertensives or IV inotropic drugs as well. Sometimes some of the potential complications of infection, of IV medications, we can cause infection at the site itself, or we can, as we're giving the medications, not clean the port well and push bacteria into the vascular system. If we're not careful, we potentially could give an air embolism. We could have a clot embolism that may be potentially in the IV that we're using for the patient, and we potentially could dislodge a clot. And then sometimes we can cause this drug particle embolizations that occur, and not really all forms of the same drug are appropriate for IV administration. And those could be, some examples could be insulins that I've provided here, glargine versus regular, and they really can. So it's always important for you to read your labels very carefully and make sure that what you're giving to the patient is an IV concentration. Make sure that it says for IV use. That's really important. So IM injections intramuscularly, or IM, this will allow us to place some medications into the muscle itself and allows a very quick, rapid administration. These are suspension drugs, or drugs that are poorly soluble that can't be given via mouth or IV. So there's also some medications called depot preparations. These are medications that can be absorbed slowly over an extended period of time. And typically you think about medications like birth control over the course of time. Sometimes we potentially could go to the doctor's office and you have an infection and you may get an IM injection, and you don't have to take 10 days worth of an oral antibiotic, because you've already received this suspension by this depot preparation that will be absorbed slowly over an extended period of time. And there's an example here for you. So penicillin component of benzathine combination will release their therapeutic amounts over potentially a month or more. Sometimes they're shorter, or sometimes they're various months or years. And some of the complications with that, if you're giving this kind of medications, you potentially can cause a lot of pain for the patient. Those IM injections can be painful. Also, it can cause some tissue injury or potentially some nerve damage. So make sure that you're giving these medications in the correct place and the correct technique. Typically, we're going to use a 21.5 to a 22 gauge needle. And you really want the needle to be about 1 inch to 1.5 inches in length to really be an appropriate depth. So keep in mind that IM drugs are similar to IV drugs that go directly into the capillary beds, so that the blood vessels then that feed those areas are going to be absorbing that medication. Subcutaneous, you're going to learn that this is going to be administered below the skin, but above the muscle. So sites that you can administer sub-Q injections are going to be on the upper arm, the thigh, the abdomen. We're going to use that even smaller gauge needle, 25 gauge. Now, you have to remember, the higher the number of the gauge, the smaller or the tinier the hole in the bevel of the needle. And then some of the pharmacokinetics are really nearly identical to intramuscular medications, but you really have to create an area that there's really no significant, you have to choose an area that's really no significant, there are no significant barriers to that absorption. So if you have a patient who may have cellulitis or a big bruising or something like that, you really don't want to give those medications, sub-Q medications, into those areas, because those sub-Q areas have been compromised. So as with any kind of IM injections, you have to think about where the blood flow is and what's the drug solubility, and are there, really any other components in those major determinants that potentially could cause some problems. And there are some same disadvantages of sub-Q administering as there were to some IM injections. There's some other parenteral routes that you potentially could be giving patients. They are intraosseous or IO. If you have a patient who has an IO administered during a code, then we can administer those medications, and typically they're in the humerus or in the knee. There's intra-arterial medications that can be given. There's also epidural, into the epidural space that's around the spinal cord, that could be administered as well, and intrathecal, and those are medications that are administered subarachnoid, into the subarachnoid space, and those drugs are bypassing the blood-brain barrier, and some of those things could be chemotherapeutic agents that potentially could be administered for those patients with those kind of cancers. So I'm gonna stop talking and recording here. So we will pick up in class with the per os or by way of mouth discussion. Thank you.